presentation.
So it is a very interesting case. The details will be shared by Dr. Pinky. Dr. Pinky, you can start. You can share your screen.
Okay, so good evening, everyone. I'm going to present a very rare case with a refractory hypotension post-sympathectomy neurolysis. We have to just think for the cause of hypotension post-sympathetic neurolysis. I'm Dr. Pinky Ratnani. I'm practicing attending consultant in RGCIRC, Niti, Bagh. Next. Next.
Yes, I'm trying. So
I think you have to get it on a presentation mode.
yes. Okay. Go ahead.
Yeah. So my patient is 55-year-old male patient whose journey started in February 2020 when he was diagnosed with carcinoma esophagus at RGCI Niti Bagh with no comorbidity, no family history of cancer, no any medication history, no past surgical history, except he had a history of chronic BD or in the cigarette smoking. So plan was made for chemotherapy and radiotherapy followed by surgery. So he received 5 cycles of chemotherapy and 23 cycles of radiotherapy. According to the plan, after chemo and radiotherapy, he underwent surgery on June 2020. The robotic Machions esophagectomy was performed. So on follow-up PET scan in October 2022, which was showing the active celiac lymph nodes, and on FNSE, which were metastatically poorly differentiated squamous cell carcinoma. So plan was made for palliative chemotherapy. So he was given 8 cycles of chemotherapy of injection Folfox. And on repeat PET scan in March 2023, again his findings suggestive of the increase in abdominal node activity, and he started having back pain. For increase in abdominal node sizes, he received 15 cycles of palliative radiotherapy, and he was also advised for immunotherapy, but patient was not willing for immunotherapy at that time. So he was started on weekly chemotherapy of paclitaxel and carboplatin. So in November 23, he started having abdominal pain and back pain with a VAS of 5 to 10. And he started having weakness, breathlessness on and off. And he visited in our OPD where he was started on analgesic medication as per WHO ladder, which includes morphine and fentanyl also. As his pain worsened, his MRI dorsal spine and LS spine was done. Dorsal spine was not suggestive of any significant finding, but the LS spine was suggestive of L4-5 disc bulges. But the diameter, spinal canal diameter was 11.5. His CT abdomen was also done at that time, which was suggestive of query left renal vein thrombus. So in the view of left venous thrombus, celiac plexus or the splenic plexus block was not done. His abdominal pain was continuously increasing. So cardiologist's opinion was taken for coronary and the renal angiography. After clearance from cardiologist, his celiac neurolysis was done in January 2024. And he became better in pain. And his WHO ladder was continued and follow-up visits were continued. Meanwhile, he had undergone sequential PET scan, which shows disease progression. So in January 2024, he agreed for immunotherapy, which was started in January with injection nivolumab 140 milligram, which was given every 2 weeks interval. In June 2024, he was having severe abdominal pain due to disease progression. So again, he was given bilateral splanchnic nerve block. MIPSI was done. RFA was done at T11-12 in June 2024. His immunotherapy was still going on. During his visit for immunotherapy, he was constantly complained of drowsiness, dizziness, fatigue, and weakness. His BP was low. He was given bolus fluids, and then immunotherapy was given. He used to have low BP on consecutive visits and also started on tablet Hyson 10 mg for 10 days. Slowly, he started feeling better. His BP was normalized. In July 24, he developed cholelithiasis with choledocholithiasis with features of obstructive biliopathy, for which he was advised ERCP, but due to stricture, the stent couldn't be placed and he was managed conservatively. Again, lesion increased and it involved right ischial spine compressing nerve bundles. So he was started having severe pain, which was managed conservatively, and biopsy was taken from the site in December 24. In March 2025, he was diagnosed to have bony tuberculosis, and for which he was started on ATT HRZD for 6 months, which completed in September 2024, 25. So after starting anti-tubercular treatment, he became weak, multiple episodes of vomiting. So his immunotherapy was withheld for some time. In May 2025, again, he started having severe abdominal pain, for which again, he underwent bilateral splanchnic RFA. His next nivolumab dose was withheld in a view of hypertension post-procedure, and subsequent PET scan showed progression of disease. In June 2025, he was admitted in hospital for hypertension and found to have a DVT at PICC line site in left upper limb. Doppler suggestive of partial intralunar hyperechoic content of the subclavian vein. Rest of the vessels were normal. PICC line was removed and hypotension was corrected. In September 2025, again during his immunotherapy day, he had low BP, tired, fatigue, and he was reviewed by cardiologist in a view of old left renal thrombus, and an endocrinologist opinion was taken. Endocrinologist made a diagnosis of nivolumab-induced hypophysitis after investigating thoroughly his ACTH, cortisol, prolactin, TSH test, repeat TSH levels, and repeat PET scan was done to confirm that no uptake in adrenal and pituitary gland were present, and he was started on tablet Hyson and tablet Thyronorm. On February 2026, he received his last nivolumab. His BP was 90 to 100, just normal, with no complaints of any weakness or fatigue. And he is off tab Hyson, and he continued his glucocorticoids for 3 months, and his Thyronorm is still continuing. So this is a journey of almost 6 years from 2020 to 2026 till date. So important events of this case are, he's a case of CA esophagus, post-surgery, post-radiotherapy, on chemotherapy, and palliative care. He received he undergone celiac neurolysis and 2 times bilateral splanchnic RFA. He took ATT. He has a history of thrombus in renal vein and subclavian vein. He is on ongoing nivolumab chemotherapy. Initially, he was stable and now in a progressive phase of the disease. He is ECOG PS1 and he is diagnosed with hypophysitis. So, cause of hypotension in this case. There are multiple thoughts during his journey and different events he underwent. So, the causes can be like post-celiac neurolysis, sympathectomy, sepsis, poor intake due to anti-tubercular treatment, progressive cancer, renal vein thrombosis, PICC line thrombus, anemia, electrolyte imbalance, metastasis due to cancer. So celiac plexus block, generally orthostatic hypotension for 40 to 72 hours is expected, but sometimes it can go long lasting. Hypotension can be seen for weeks, which can be managed with hydration and IV steroids. This patient was admitted for hypertension, and cause of sepsis was suspected. So due to sepsis like hypovolemia and decrease in vascular tone, there was reduced blood flow in vital organ causing hypertension might be the cause. As he was on ATT, so nausea, vomiting, anorexia can lead to severe depletion, severe volume depletion, which may cause hypotension. Progressive cancer, cachexia, muscle wasting, rapid weight loss, and decreased muscle mass compromising venous return to heart, causing the hypotension. PICC-related venous thrombosis can lead to pulmonary embolism or the right atrial thrombus, which can manifest in hypotension. Chronic anemia, it reduces oxygen carrying capacity, which compensate with vasodilatation, and which leads to decrease in blood pressure. Cancer and its treatments causes the severe electrolyte shifts, causing hyponatremia, hypokalemia, hypercalcemia, which disrupts the cardiac rhythm and decrease vascular tone, leading to hypotension. Hypotension in patients with metastatic cancer caused by the retroperitoneal lymph node lymphadenopathy, compressing inferior vena cava, significantly reducing the venous return to the heart, and this is also known as inferior vena cava syndrome. These are the usual causes of hypertension which we can think of, but there's a new culprit in this case is the nivolumab, which is a newer immune checkpoint inhibitor. It is a recently launched drug. It is a monoclonal antibody that selectively binds to programmed DET1 receptor on the T cell blocking tumor cells for evading immune detection. This blockade enhances T cell response, boosts the immune system's anti-tumor activity, and ultimately contributes to the destruction of cancer cells. These immune checkpoint inhibitors are associated with common immune-related adverse effects like dermatitis, enterocolitis, hepatitis. And it can present with rare immune adverse effects, which are very less, like 0.5 to 1% can be seen, like hypophysitis and adrenal insufficiency with isolated ACTH deficiency, in which the immune system trigger against normal tissues of the body, including the pituitary gland. These side effects can occur anytime and does not depend on dose of the drug. This immune-mediated attack can lead to inflammation and dysfunction of pituitary gland, resulting in hormonal imbalance, including adrenal insufficiency, hypothyroidism, and hypogonadism. Patients often present with fatigue, anorexia, headache, or electrolyte imbalance, hyponatremia, leading to hypotension. This can be confused with malignancy progression or chemotherapy side effects. Treatment with nivolumab-induced hypophysitis is replacement of glucocorticoid, which induce inflammation and restore hormone balance, leading to improvement in symptoms. So it's very important that patients should be educated regarding rare side effects of drug with its presentation, regular follow-up, and monitoring for endocrine complication, as early recognition and intervention leads to better outcome. Thank you. And I also would like to thank Dr. Sunny Malik sir, who helped me with this presentation, and to my patient, without whom I would not be able to present this case. Thank you so much. Thank you.
So thank you, Dr. Pinky, for the presentation. So to summarize, this patient, around 66 years old, he is post-surgery. Gastric pull-up surgery was done in 2020. He was post-RT, 23 cycles was given, initially having stable disease. Because of the financial constraints, initially he was on weekly chemotherapies, and later on, when there was progression of disease, so he was started on this nivolumab in 2023. He was first referred to us in a very bad shape, having pain, and he was started on the WHO ladder. As a protocol, we admitted the patient, we titrated the dose of morphine and fentanyl, and he was shifted to fentanyl patch 25 microgram per hour with add-on SOS tablet morphine, normal release 10 mg. In January 2024, first celiac plexus neurolysis was given, And later on, in June 24 and May 25, bilateral splanchnic RFA was done. The first doses after the first bilateral splanchnic RFA in June 24, patient had first episode of hypotension and fatigue. For that, the treating oncologist, he started hydrocortisone tablets, and initially IV hydrocort was given in thrice daily dose for 3 days, and later on shifted to hydrocortisone tablets, and they were given for 1 to 2 weeks, and he was okay. And again, this nivolumab was started because there was a suspicion of this hypopituitarism by the treating oncologist at that time. In May 25, he again came. At that time when we gave second bilateral splanchnic RFA, everything was explained to him कि BP गिर सकता है और ये सब हो सकता है. But because of the condition of the patient, and patient had a very good rapport, we had a very good rapport with the patient and the family. They were ready that we want to go for the procedure again, and then this splanchnic RFA was done, and primary team, that is the treating oncologist, was also taken into the loop after planning this. After this second bilateral splanchnic RFA done in May 25, he had repeated episodes of hypotension. And by that time, almost more than 20 doses of nivolumab were instilled and they were given to the patient. And this was the time, normally जब भी BP fall होता है, तो we look for the causes as shown in the presentation, that it might be due to sympathectomy, due to the parasympathetic dominance. This was the first thing. He was also taken care that the HB remained more than 9. Even हम लोगों ने उसको जो first admission हुआ था at the HB of 9.5, because the BP was 80 systolic. So after admission, 2 units of packed RBC transfusion was given, knowingly that this patient is on anticoagulants and having a clot, but BP was the main cause. Third, because of these patients are on immunotherapy, so TLC can go up and down. So sepsis का भी पता नहीं चल रहा था उस TLC को देखते हुए. So Procal was done, although Procal was normal, but he was given IV doses of antibiotics also कि कोई sepsis का component immunocompromised state को देखते हुए वो cover हो जाएगा. Low albumin status. Normally we had a protocol of transfusing albumin, giving albumin if the albumin is less than 2.8, but at albumin of 3, because of the low BP, albumin was also given for कि अगर उसकी वजह से कुछ हो रहा है. Sodium correction was given, so he was started on salt tablets as well as the ORS for increasing the BP. Next, fluid losses were also maintained. He was advised to take IV normal saline at home after the discharge. So this was also done. 2D echo was also done. And we took the opinion of the cardiologist also, and the EF was normal and there was no regional wall motion abnormalities. In this case, it was also ruled out. Multiple HbA1c levels were also seen, because high HbA1c can also lead to autonomic dysfunction and orthostatic hypotension. So that was also ruled out. Plus, initially, ESH and PFT profile was done by us. So at that time, initially, after the second this RFA and the third RFA is time frame के अंदर TSH were perfectly normal and they were done every 1.5 months. उसको भी rule out किया. So after all these, and plus this midodrine tablets, they were also given to the patient in a dose of initially 2.5 milligram thrice daily, which were increased to 10 milligram thrice a day. These are alpha-1 agonists, which are vasoconstrictor medicines. They are sympathomimetics. They were also started in this patient for increasing the BP, and a vasoconstrictor, that is coffee, was also given. उसको बीकासूल के कैप्सूल के अंदर कॉफी पाउडर डालने के बाद में 4 times a day coffee was also given for increasing the BP, and ultimately, lastly, endocrinology referral was done, and he came for our rescue, and he was found to have this anterior pituitary dysfunction. This was the hypothesis for this case, having secondary adrenal insufficiency, and he was started these Hyson tablets in 10 milligram doses, and they were continued for 3 months. And after that, this patient is okay, as told by Dr. Pinky, and he is on regular follow-up in the palliative care clinic also, apart from the immunotherapies. So this is the total picture. And one more thing I want to add, that not only this autoimmune pituitary involvement can occur, the autoimmune involvement can range up to this thyroid dysfunction, adrenal dysfunction, pituitary, myocarditis can also happen with this medicine, hypersensitivity reaction and plus pneumonitis. Pneumonitis अगर nivolumab या किसी भी immunotherapy से हो जाए, it is an indication कि you have to withhold this and stop this immunotherapy आगे के लिए. And recently I discussed this case with our oncologist जो हमारे center पे है, Dr. Kapil. He said that he has seen a case of Stevens-Johnson syndrome also leading to the death of the patient. So dermatitis can also occur. So there is a grading. There is a grading which is known as the immune-related adverse events. So it has 5 grades. First grade 1 is mild. For the mild, you have to just observe. जैसे thyroid dysfunction हो गया, so TSH का आपने replacement किया, Thyronorm tablets, and you have to observe it. Then 2 is limitation of the daily activities. तो उसमें आपने कुछ time के लिए you have to hold the therapy and again you have to restart. As done in this case initially जब second RFA किया गया था. Then third is severe. Severe है लेकिन life threatening नहीं है, उसमें you have to withhold. This patient has 4th grade. 4th grade was that he was hospitalized for this hypotension episode. So now this decision has been taken that this patient, this nivolumab has been stopped. And the 5th is that this leads to death, as in that case of Stevens-Johnson syndrome. So basically, he was having secondary adrenal insufficiency, which was due to the hypopituitarism. Although there was no uptake in the pituitary gland and the adrenal, but endocrinologist referral के अंदर this was the postulated hypothesis for this refractory hypotension. Over to you.
Great, sir. You have taken palliative care to next level. 2 questions, sir. What made you think that this immunotherapy could be the cause of hypotension? Was it endocrinologist who said that it is hypophysitis, which was caused by?
So when I discussed with the oncologist at our center, so he said that initially when this is a newer medicine, it is also given for the head and neck cancers also, and it is used for the CA esophagus. So he said that initially when this medicine was started after all the trials, तो उनको भी इतने side effects पता नहीं थे. So with time they are also learning. Now many oncologists they have a protocol कि वो बीच में हर 3 महीने पे growth hormone, prolactin, luteinizing और ये LH hormone, FSH, TSH, ACTH, morning and evening cortisol, ये सब देखते रहते हैं बीच में to prevent these side effects.
So if patient is in any immuno, not only this particular immuno, and is having hypertension, we should think of having discussion with endocrinologist.
Endocrinologist.
Sunny, how will we reach the diagnosis of this adrenal insufficiency, secondary? What is the diagnostic criteria of you making this diagnosis? Yes, because in cancer patient, he is on anti-tubercular therapy, metabolic syndrome was there, cachexia was there, and weight loss was there. So many things can happen. This patient generally become weak. So why don't we think it is the general condition of the patient, gradual weakness and general fatigue, etc., setting in due to the cancer syndrome? Basically, cancer syndrome leading to all the things. But only thing is that hemoglobin and albumin was not low. That's basically goes a little bit against the thing. Otherwise, it is due to the general deterioration of the health, and you have given the blocks. And that's what can lead to the hypotension. It's not exactly very severe hypotension, but maybe 70. I don't know what is the level of the hypotension which occurred. So what is the basis of your diagnosis of secondary adrenal insufficiency?
Initially, जितनी भी चीजें होती है सर, वो एक एक करके rule out करी गई in this case. As I already told, कि sympathectomy, after sympathectomy, usually this hypotension can occur up to 1 to 2 weeks. उसके बाद जो है वो normalize हो जाता है. So everything, this hemoglobin, sepsis, these medicines like diuretics, everything was taken into consideration. And this patient, even when we admitted the patient, he was admitted thrice with us for symptom control because he was having orthostatic hypotension. सोता है तो ठीक रहता है, जैसे ही बैठता है तो उसको चक्कर आते हैं, fatigue होता है. So even with the fluid replacement and replacement of all these things like blood, like albumin, everything, the patient was not having a systolic BP of more than 90. जब फ्लूइड चल रहा होता है तो थोड़ा बहुत आ जाता है 90 तक, उसके ऊपर नहीं जा रहा. इसके अलावा देयर इज अ फ्लो चार्ट फॉर द डायग्नोसिस, वो मैंने आज ही पूरा एकदम से पूरा पुराना सारा याद किया है. सो एड्रिनल इनसफिशिएंसी में फर्स्ट यू हैव टू चेक फॉर द ACTH हार्मोन एंड द कॉर्टिसोल. सो if the ACTH is high with a low cortisol, तो एड्रिनल सिक्रीट नहीं कर रहा है cortisol को, और जो हमारी होम्योस्टैटिक मैकेनिज्म है उसकी वजह से ACTH हमारा हाई होता चला जा रहा है, जो पिट्यूटरी से सिक्रीट होगा. So basically it might be due to primary adrenal insufficiency. In this case the ACTH, next is के cortisol जो है वो बन नहीं रहा है वहां से एड्रिनल से, it is low, plus the ACTH is also low or normal. So in this case the ACTH was initially low. So in these cases you go for the other test also, as I already told, like the growth hormone, the TSH was high in this case, then prolactin, this was also deranged. So after going through these tests you come to the diagnosis of the secondary adrenal insufficiency, which might be due to the involvement of the pituitary. तो पहले आपको normal जो common causes हैं उनको ही rule out करना, even endocrinologists भी यही कहते हैं. And next thing, when he was given hormone correction in the form of the IV hydrocort and the Hyson tablets, the BP rose, BP जो है बढ़ गया. So this is also a test which is used by the oncologist and the endocrinologist. So that's how we came to the diagnosis of that this patient might be having the involvement of the anterior pituitary, and now this is a side effect which can be associated with these immunotherapies, basically mainly nivolumab. So this is how we approach to the diagnosis.
Sir, another question I had was, as you said that patient had
आवाज नहीं आ रही
thrombosis and then subclavian thrombosis. How you managed with the stopping of anticoagulation and then doing procedures?
Yes, so initially this apixaban was started in 2.5 milligram twice daily doses. Because we are at the tertiary care center, तो यहाँ पे ऐसा नहीं है कि सब कुछ आपको start करना है. You have to take the call and you have to get the references and the reviews done. So cardiologist started, he did this renal angiography and he started this apixaban. He was on apixaban. Initially, as told by Dr. Pinky, it was written in the slides that initially we were hesitant. Initially जब इनकी apixaban start हुई है for the renal thrombosis, so we were not keen for doing any celiac plexus block. This was written in the slide. Right. But when this WHO ladder was not up to the mark for controlling the pain, so after 3 months a decision was taken after consulting the cardiologist, and he gave the final clearance that yes, you can stop this dose of apixaban for 4 to 5 days and you can go for the procedure. High risk consent was also taken while planning this procedure, क्योंकि जो resultant vasodilation होगा वो थ्रोम्बस को माइग्रेट भी कर सकता है. बट यूजुअली ऑन्को केसेस के अंदर जो क्लॉट्स होते हैं वो ट्यूमर थ्रोम्बस की वजह से होते हैं, एंड दीज ट्यूमर थ्रोम्बस आर यूजुअली नॉट सो फ्रेजाइल, ये कहा जाता है. द सेकंड क्लॉट व्हिच वाज इन द पिक लाइन, द सेकंड क्लॉट दैट माइट बी फ्रेजाइल बिकॉज इट इज अ ब्लड क्लॉट जो कि स्लाइम लेयर के बनने की वजह से आता है एट द टिप ऑफ द पिक लाइन, सो दैट माइट बी फ्रेजाइल. But as far as this clot in the renal vein is concerned, these are usually not fragile because these are usually the tumor thrombus. So this was the discussion done with the cardiologist, and he said that I am giving you a green signal that you can go for the sympathetic neurolysis. But ASRA guidelines, they were followed.
Got it.
Dr. Sunny,
Yes, sir.
you gave 3 blocks, sympathetic blocks. In
Yes,
how much
sir.
duration time? But what was the total time during duration?
So first celiac was given in Jan 2024. Then in June 2024, bilateral splanchnic RFA was done. And then May 25, another bilateral splanchnic RFA was done. So this was the time frame as per the dates.
6 months.
So
kind of 6 months.
This patient is alive. This patient is alive.
Yeah, that's okay. That's okay. But if suppose you have given celiac, you have given splanchnic, and now again you gave splanchnic, what was the criteria? Because if you are doing neurolysis,
yes, sir,
then you don't repeat it so frequently. Generally you don't repeat it, because if it is not working, it is maybe technically if one feels it is not, because if you have done it correctly, because you are such a sound this thing, so there is no question of not going to the point. Basically technicality is ruled out. There is some problem. Then what made you think, in spite of having hypotension and patient going all these things, you have to give the sympathetic block for third time?
The third time it was given in May 25, and the time frame between these two procedures was almost 12 months. June 24 के बाद सर अगला जो है May 25 में किया गया था, और उसके पहले जो June 24 के बाद जो BP फॉल हुआ था, it was within a time frame of 2 weeks. और उस टाइम में हाइड्रोकॉर्ट वाज गिवन बाय द ट्रीटिंग ऑन्कोलॉजिस्ट, और उसके बीच में BP was normal. सेकेंड RFA जब किया गया in the May 2025 with the progression of disease in the PET scan, because progression भी साथ साथ हो रहा है and the pain was increasing at that point of time, second RFA was done. उसके बाद जो है BP का persistent fall होना start हुआ था.
Thanks.
Yes sir.
Okay. Very thought-provoking presentation. So let's move to. I said बहुत सारे questions there, but we are in like limitation of time. So we'll proceed with the second presentation. Dr. Poonam, are you able to share your presentation? Can you?
Yeah, ma'am. I'll just try. Yeah, I'll just do.
And meanwhile, I'll thank Dr. Pinky. She has been answering all the questions asked in chat box, saving us the time. Thank you, Dr. Pinky.
Thank you, ma'am.
All right. So Dr. Poonam, she is done her fellowship in pain medicine from Toronto, Canada, and currently she is working as assistant professor in Department of Anaesthesia, Critical Care and Pain Medicine at UCMS and GTB Hospital. So your face and your presentation is
Are
half
you able
half.
to see, ma'am?
Yeah, we are
Yes,
able to make
you
it
can
full
see.
screen. Maybe then we can.
Yes. Just give me a second. Is it okay now? Visible, ma'am?
Yeah, but then it's
Full screen.
yeah,
Yes,
she has
full screen
made
only.
full screen, but your face is coming half and half. Can you see that?
आप मैडम फुल स्क्रीन दिख रहे हो, प्रेजेंटेशन छोटा दिख रहा है.
Okay.
Presentation छोटा दिख रहा है.
Okay. Let me do it again then. I'll stop sharing. I'll just stop sharing and share it again. Just the presentation. I'll show.
आ गया था.
Just a second.
Yeah.
One more time. I'll do content only, then it will come full screen, I think. Now?
Yes.
How is it? Now it's
Yeah,
visible?
make it full screen, and then I think it's
Yeah,
better now.
doing.
It's better this time.
Just a second. Stay.
Yes, perfect.
Is it visible, ma'am, now?
Yes.
Okay, so good evening, everyone. My name is Dr. Poonam Rani, and I am Assistant Professor in Department of Anaesthesiology at UCMS and GTB Hospital, New Delhi. I would like to thank ISSP team as well as Dr. Aanchal for giving me this opportunity to present our case today. So we will be discussing a case of trigeminal neuralgia. So a patient of 47-year-old female presented to our pain clinic in November 2025, and she was referred from neurology from IBAS hospital. She has a complaint of pain over left upper cheek for 8 years. Along with the pain was also over the left upper lip and upper jaw. Pain was sudden in onset, feels like electric shock, and was severe in intensity. In the beginning years, the pain episodes were occasional, like once in a few months, and used to stay for 30 to 40 seconds. And slowly now it progressed to 30 to 40 minutes and with 2 to 4 episodes per day. Pain was triggered by a cold breeze, chewing food, washing face, and brushing teeth. Other than that, there was no history of motor deficit, no history of rash, visual disturbances, numbness, or trauma. Apart from this, there was no other positive finding in sensory and motor examination. There were no other cranial nerve involvement. Sorry, I think the slides have moved. So this is my disclaimer. On investigations, MRI brain was done, which was reported normal, and there was no aberrant vessel or other vessel compressing the trigeminal nerve root. So it's a typical case of trigeminal neuralgia and symptoms corresponding to the maxillary division. When patient came to us, she was already on tablet carbamazepine, almost 1400 milligram per day, tablet lemotrazine, 50 milligram twice daily, tablet gabapentin, 300 milligram twice daily, and tablet baclofen, 10 milligram twice daily. In the past, patient was already referred to dental examination, and it was came out to be normal. In neurology, she was already given above treatment. And in the beginning year, she was responding to the treatment. She was managing well, but slowly the medical treatment started failing. And then the neurologist, that he did the landmark guided distal great occipital nerve block. First two injections went very well and gave patient 5 to 6 months of good relief. After the third injection, patient did not have any relief in the pain. Then weekly injections were tried for 3 times with the same landmark guided distal approach, but patient did not respond to it and she was in severe pain. Neurosurgery opinion was then sought for possibility of any surgery, but surgery was denied as MRI had no abnormality and surgery was least likely to improve the symptoms. So when she came to our clinic in November 2025, I was also very much influenced by her symptoms and was so tempted to perform the maxillary nerve injection. But just I had one thought that patient responded to great occipital nerve block previously 2 times, and then why again she did not respond. So I thought, okay, let's give one try for the great occipital nerve block first, and if she doesn't respond, then I'll try the maxillary nerve or the trigeminal rhizotomies. So I did USG guided great occipital nerve block by proximal approach in the end of the November 2025. At that time, her pre-procedure pain score was 9 out of 10 and she was wincing in the pain on the OT table also. 1 hour after the procedure, her NRS was 7 out of 10. During the follow-up visits in December 2025, her NRS score was 3 to 4 out of 10 with decrease in frequency of the pain episodes. She first time ate solid food in last 3-4 months. So she was better and I stopped baclofen at that time. In February 2026, she again came for follow-up and that time her pain score was 0 on medications and there were no pain episodes in last 1 month. So what is trigeminal neuralgia? It is typically patient presents with a multiple short-lasting paroxysms of the severe pain, usually on one side of the face, and patient described it as lightning bolt to the face. Maxillary and mandible divisions are most commonly affected. Sometimes in 5% patients, ophthalmic division can also be involved, and it is associated with mild autonomic symptoms as well, like lacrimation, rhinorrhea, and conjunctival injections. Commonest etiology is vascular compression of the nerve root, and superior cerebral artery is most commonly involved. However, petrosal vein, anterior inferior cerebral arteries, or vertebral arteries can also cause compression of the trigeminal nerve. It has been found that in patients, 2 to 4% of symptomatic patients of multiple sclerosis, patients can have trigeminal neuralgia. These patients can have the trigger zones mostly near to the midline, like over the angle of the mouth or nose. And when they are present, this is almost pathognomonic and diagnostic of the disease. Talking about the epidemiology, incidence of the trigeminal neuralgia is 4 to 13 individuals per 1 lakh individuals annually. Women are most commonly involved. Peak age is around 50s, but it may occur in the younger age as well. So according to ICSD-3, trigeminal neuralgia has been classified into 3 groups, like classical trigeminal neuralgia, secondary trigeminal neuralgia, and idiopathic. In classical variety, it is generally attributed to vascular compression of the trigeminal nerve or its roots, while secondary is due to some space-occupying regions or lesions or multiple sclerosis, while there is no cause in idiopathic. It is also classified as type 1 or type 2, where type 1 there are only paroxysmal episodes, while in type 2 there is a constant pain without superimposing paroxysmal episodes. Diagnosis based mainly on the clinical features, where recurrent paroxysms of unilateral facial pain in the distribution of trigeminal nerve and fulfilling criteria B and C, which says pain should have all the following characteristics, like pain lasting a fraction of the seconds to about 2 minutes, which is severe in intensity, electric shock like sharp or shooting pain, and is precipitated by the inequous stimuli. And there should not be any other alternative diagnosis which explains the symptoms. So before making the diagnosis of trigeminal neuralgia, other causes of the facial pains, they should be ruled out, like the post-herpetic neuralgia, dental or odontogenic pains. They can be SUNA or Sun City, trigeminal neuropathies, temporomandibular joint syndromes, or glossopharyngeal neuralgia, which can also cause the similar picture. Talking about the treatment, irrespective of the etiology or type of the disease, pharmacotherapy is the preferred treatment. First line modality in pharmacotherapy is carbamazepine, which is the only drug which has been approved by the FDA, and oxcarbazepine. Second line drug therapies include other anti-epileptic drugs like carbamazepine, clonazepam, lamotrigine, phenytoin, valproic acid, etc. Surgical therapies or surgical intervention is done when there is any abnormality in the MRI and it suggests that there is a vascular compression, vessel compressing the trigeminal nerve root, and in that procedure microvascular decompression is done. We pain physician, we do thermocoagulation or chemical neurolysis and mechanical balloon compression of the trigeminal nucleus. Peripheral nerve blocks, they can be performed on the peripheral branches of trigeminal nerves like supraorbital, depending on the area involved and the symptoms of the patient. Other newer modalities like deep brain stimulation, botulinum toxin injections, and radiotherapy have also come as a part of the treatment. So why greater occipital nerve block? It is a low risk, minimally invasive, and generally well tolerated procedures. Although mostly it is done in the headaches like migraine and cluster headaches, but studies have now suggest that it can be effective in cranial neuralgias and trigeminal neuralgia. It is specifically effective in trigeminal neuralgias along with accompanying in patients who have accompanying neck pain and cervicogenic headaches. So proposed theory is modulation of the pain processing as greater occipital nerve block. It targets the anatomical and functional connections between the second cervical and trigeminal fibers, which are part of the trigeminal cervical complex, by attenuating the hyperexcitability of the neurons. So it is this is a study which was published in 2025, and in this it is a retrospective cohort trial which examined the medical records of 26 patients which came to the headache clinic, and after these 26 patients, 12 were trigeminal neuralgias. A standard 2.5 ml mixture of 30 milligram 2% lidocaine and 4 milligram dexamethasone was injected bilaterally as a single dose into the nerve region of the patients, and they were followed. In the they say that the positive response was at least 50% reduction in the pain from the baseline, and found that 22 out of the 26 patients responded to it. Response to treatment was observed in 10 patients in the trigeminal neuralgia patient, which was 83%. They also found that the post-GON block intensity of the pain as well as the sensitivity to trigger zone decreased significantly, and concluded that the GON block, they reduces the duration, frequency, and intensity of the headaches as well as the need of acute analgesics in the neuralgia and facial pain patients. There is another study which was published in 2020 and 2012 in headache and pain, and they involved 20 patients out of which of the craniofacial pain syndromes, out of which 8 patients were of the trigeminal neuralgia, and they found that they have 55%, their rate of improvement was 55% of the patient, they responded to GON block with greater efficacy found in the trigeminal neuralgia patients. They also found that occipital nerve blocks, they are effective in trigeminal pain involving the second and third branch of the trigeminal nerve, and seems to be most effective in craniofacial neuralgias. Also, I came across a study which shows a comparison of the clinical efficacy of the GON block at the C2 and level as well as with the distal approach in the cluster headache patients. So they divided 48 patients diagnosed with cluster headache into 2 groups. One group received injection of the GON block at the C2 level, other one received at the distal block. And they found that both GON block techniques, they were effective in reducing the cluster headache symptoms. Patients treated with the C2 GON block, they achieved complete pain relief by third week, allowing for the treatment cessation. In contrast, the distal GON block group, they require up to 6 injections for the similar levels of the relief. So how I did the procedure and how I usually do it. So I do this procedure by the proximal approach at the C2 level. So we put the ultrasound probe, scan it from the caudal, from the superior nuchal lines, put the occiput and then see the superior nuchal lines, and then come down tracing the atlas and axis vertebra. So there is and identify the bifid spinous process of the C2. From there, we just move the probe laterally and align our probe in the axis of the oblique inferior capitis muscle. And then this shows a picture like inferior oblique capitis muscle, which is a like boat-shaped muscle, and above it is lying the semispinalis muscle. And the greater occipital nerve lies in this plane. Sometimes it may not be possible to visualize the vessel and the nerves, and that time we can just infiltrate the local anesthetic in the same plane. So there are various landmarks doing for this procedure. So also, as I already have told, so there are bony landmarks and inferior nuchal lines, supernuchal lines, and then going down to find out the arch of the atlas, and then further going down to find the bifid spinous process. And from there, we move the probe laterally to find out the oblique capitis inferior muscle and the semispinalis muscle. Vertebral artery lies quite lateral to the greater occipital nerve and the vessels. So, and this should be avoided. Generally, in-plane approach is preferred. However, the experts, those physicians who are quite expert, they also go out of plane. I generally follow the in-plane approach from lateral to medial side. So, in summary, greater occipital nerve blocks, they can be considered in trigeminal neuralgia and other facial pain patients before adapting to the invasive approaches, given that the side effects are mild and the procedure is minimally invasive. Ultrasound-guided GON blocks at the level of the inferior occipital capitis muscle, they are target-specific and probably more effective than the distal approach. These are my references. Thank you for your patient listening.
Yes, great, Dr. Poonam. Pradeep sir, any?
मैं एक चीज पूछ रहा था कि what agent you injected in the
Triamcinolone. Yes, sir. I injected 40 milligram of triamcinolone in 2% lidocaine. Total volume was 4 cc.
What is the duration of pain relief?
So still now patient is having the pain relief, although she has some aggravation in her symptoms during the January when there was extreme cold was there. That time for 15 days her patient.
मेरा भी 30 साल से ज्यादा का एक्सपीरियंस है रिगार्डिंग ट्राइजेमिनल न्यूरल्जिया पेशेंट सर्वाइकोजेनिक हेडेक माइग्रेन में सर्वाइकोजेनिक हेडेक में यूज करते हैं ग्रेटर ऑक्सीपिटल नर्व ब्लॉक ठीक है दैट इज ओके बट गेटिंग treating trigeminal nerve with local anesthetic and you say it provides very long duration and excellent pain relief is somewhat not digestible. Because what we do the neurolysis also. Initially, we used to do peripheral neurolysis, then the gastric ganglion block, and now the radiofrequency. And even after localizing, accurate localization under image guided, sometimes it is very difficult to treat it, and patient may not get complete pain relief. So this is somehow you may be right. I don't say this is not correct or something like that. That's not my thing. But from my experience, it's a very good thing. अगर greater occipital nerve block करने से ही trigeminal ठीक हो जाता है बिल्कुल. जब medullary division था, you could have tried the peripheral approach, distal approach करके.
That's what I wanted to
explain. gastric ganglion करना चाहिए था. क्योंकि अगर trigeminal की diagnosis है trigeminal की, तो फिर वही करना पड़ेगा डिवीजन. I don't say you are wrong. You may be right. जब मेरा पर्सपेक्टिव है इतने सालों का वो गलत हो जाता है.
Pradeep, can I add something?
Yeah.
What I was trying to say, this is a clinical diagnosis. there is no MRI diagnosis because there is no aberrant vessel which is, abutting the nerve.
Maybe, whatever may be, whether it
Sir,
is
sir,
the
can
MRI
I
diagnosis there or not, it is
can
trigeminal neuralgia.
can I say something here?
Ah.
Dr. Poonam, this is Dr. Ashu.
Yes, sir.
So, what prompted you to go to occipital nerve rather than my question is, what was the clinical finding in your patient which prompted you to take this
Yeah.
approach rather than going for trigeminal nerve RFA? This is first question.
Yes, sir. So I was also very much tempted to perform the maxillary as I already told in my presentation, because I wanted to do that. But because the neurologist has performed twice gone block and it was effective, and further were not effective, so I just had it, and he was doing the blind approach, so I just had it, okay, let's give it just one try. If and I was also from on your side that I was like 90% chance it may fail, but somehow
No. I tell you what. सर प्रदीप सर, आपको याद है मैंने ये केस प्रेजेंट किया था, बायलेटरल V1 था, बायलेटरल C2C3 था, पेशेंट को दुरेजा सर की कॉन्फ्रेंस में 5-7 साल पहले, आपको याद है? दिस इज सिमिलर काइंड ऑफ इशू, यू नो डॉक्टर पूनम, when your trigeminal neuralgia is related to pain starts from your neck, on pressing C2, C3, the pain is referred to front. All these cervicogenic symptoms are present. That is the case which may present as trigeminal neuralgia. I had a patient which had bilateral V1, V2 trigeminal neuralgia, bilateral C2, C3 neuralgia. So we did one side V1, V2. She was okay. But then I realized, is the pain is coming from back. Then we saw there was on the other side, there was a severe C2, C3 pain. So we did C2, C3 RFA. Both was treated in single go. Also C2, C3 and trigeminal neuralgia. So all those patients,
सर्वाइकोजेनिक हेडेक है, एक
so this is what,
सर्वाइकोजेनिक है,
so
एक ट्राइजेमिनल है, वो दो अलग-अलग है।
नहीं, मैं आपसे ये कह रहा हूँ कि ट्राइजेमिनल न्यूरैल्जिया भी प्रेजेंट होता है, बट पेशेंट हैव सिम्पटम इन द नेक. If patient doesn't have sign and symptom in the neck, there is no point on jumping to giving occipital nerve block. And they might be hardly, as you are saying, maybe 2 patients out of 100 that will in trigeminal neuralgia, which will have cervical symptom, and pain is also referred as trigeminal neuralgia. Otherwise, with this seems like a classical trigeminal neuralgia, you will see so many patients where there is a no loop, and you do V2, V1 or V2 ganglion RFA, and the job is done.
Atypical facial pain जो होते हैं,
typical facial pain, typical trigeminal neuralgia. Even in this case, if you want to give a permanent relief and you suppose that the pain is coming from the cervical neck, you have to do RFA of C2, C3, and then it will be a permanent solution.
I know, sir. I'm still waiting for how the patient behaves, and I'm also like thinking that how if the patient again comes to me, and because previously also she has relief for 5 to 6 months and then came back. Maybe the disease in remission. I don't deny.
RFA करना चाहिए था अगर करना था तो ठीक
on your side.
और ये बात थी,
maybe it is a teaching for us also. I'm not saying.
तभी तो ये रेयर केस है. Another issue is,
because I was also surprised for this thing that she has good relief, and this was the reason that I just want to check whether the patient, whether the procedure was done before was effective or not, and if it is not effective, let just me cross check it.
साइकोलॉजिकल इवैल्यूएशन कराया था पेशेंट का, ठीक तरीके से किया था साइकोलॉजिकल इवैल्यूएशन.
So patient बिचारी, I cannot tell you, like when she came to me, she was just she was covering her face all over, and she was on semi-solid diet. She was not able to chew anything. But now
any trigeminal neuralgia would do.
Another thing I want to emphasize is the MRIs, because it depends if the patient comes to you with the normal MRI, if they have not done a specific CISS.
Yes, it has to be trigeminal sequence.
So you have to check where this patient has got the MRI done, because most of the radiologists, if they are not doing in a high volume centers, they will just report it a normal MRI.
Normal, yes.
Yeah.
It has to be trigeminal sequence.
It was done at RML hospital, so I don't think that they have done that. So it was done at RML hospital, and then the neurosurgery opinion was also done. So I'm like, I still say that I'm not saying it 100% thing, but it is there, and literature is also coming up, although evidence is not that much. So that's why
not for this patient, but
and I wanted to take your opinion.
You have to take this MRIs very seriously, because they may have been reported erroneously, or the physician might not be having experience in certain kind of particular sequences.
We can consider it again if the patient's symptom flare up and all, then we may consider repeating them.
If need be, you feel free to repeat an MRI with specific sequences.
Yes, sir. That
from a particular place where they are doing high volume MRIs, and they are very well aware of these problems.
Can I make a comment here?
Yes, please, Ashish sir.
So basically, what I think is Dr. Poonam might have chanced upon some anecdotal case reports in which doing a GON block might have helped trigeminal neuralgia patients as well. So that is quite very possible, because till now, what we have been discussing over here is the classical trigeminal neuralgia. We are not talking about the primary, where the problem is in the nerve itself. So basically, what has been seen in primary trigeminal neuralgias is the presence of some hormones, especially PACAP, that is pituitary adenyl cyclase activating peptide. So this particular hormone lies at multiple places, especially the brainstem. So where especially the rostral part of the medulla, rostral part of the pons or the medulla. So if something activates this molecule, like in case of cervicogenic headache, so that also sends signals upstairs to the trigeminal ganglion, and that is how the nerves get stimulated. So when you put a GON block, the afferent signals, they decrease, the PACAP decreases, and then the patient has got relief. So that is quite very possible. Second thing, just because it is a trigeminal neuralgia, you cannot go ahead and do a RF. See, because we have seen so many number of patients who say कि मेरे को trigeminal neuralgia पहले 7 साल पहले था, हमने 2 साल अपने medications पे रखे, उसके बाद फिर वो बिल्कुल ठीक हो गया for another 5 years. उसके बाद अभी हो रहा है. So if it is primary, definitely this thing can happen. That patient may go into symptom relief even with medications. And even if many number of times you would have seen that there are vascular loops reported in the MRI, still the patient does not have pain. So it is not the presence of vascular loop which makes or breaks trigeminal neuralgia. It is basically the irritation of the nerves and elaboration of the hormones that causes the problem. So just because I have seen a vascular loop and the patient gives a symptom of trigeminal neuralgia, that should not be. Even I can go in, if I see that the symptoms are mild, I can go in for conservative management, and the patient may derive benefit. So if I can go for a conservative management, and if I have seen that there are anecdotal case reports, plus there is also a possibility of this trigeminal cervical complex. So this is a trigeminal cervical complex. What you are doing is you are decreasing the afferent signals from trigeminal cervical complex. So if that is also a possible treating modality, why not go ahead with it? I don't deny whatever you have done. I think though it might have been not have been based on a large clinical trial, but what you have done is, I think I will concur with it. I agree with your management.
Thank you, sir.
This is Dr. Jitinder. Can I speak?
Yes, ma'am, please.
So I thought it was an interesting case. That is why I joined. And I agree with Dr. Ashish. The thing I would like to add is that even superficial cervical plexus blocks, this trigeminal cervical reflex, you can use superficial cervical plexus blocks also. We have seen that. That also at times works if you do a maxillary and a superficial cervical plexus block in this patient.
Okay.
Yeah.
For how long does that last, ma'am? When you do superficial?
We have seen effect till 6 months.
See, Dr. Aanchal, again, it's not a question of how long this particular thing will last. It is something like, what I said, that even sometimes conservative management may last for years together. And we have weaned the patients out of medications after having. Yes, definitely, there are a few unfortunate group in which no matter how much you do, it doesn't help. And then definitely you have to go in for a radiofrequency. That is ablative therapy in those patients.
So you're saying if you stop the afferent signals by either superficial cervical plexus or GON block, then patient might see decrease in symptoms significantly. And it's like any other neuropathic pain that you make the pain significantly low at some point. So
see,
it
actually,
the pain
what I would so basically what I am stressing upon is how is the quality of life of the patient and how is the intensity of the pain. If it is excruciating pain, quality of life is pretty bad. He is not able to eat, sleep, or do his regular activities. Definitely the first thing in my mind would be going ahead with a RF, because that is the easiest way to finish his and stop his misery. But if I am seeing that the symptoms are not very severe, then doing a neuroablative procedure can backfire. The patient may turn up, and especially if it is type 2 symptoms. If it is type 2 symptoms, again, the patient, if you do a radiofrequency, it may backfire. So a patient may come to you saying कि अब तो मेरे को neuritis हो गया. Okay, when you, could have done away with minor interventions.
procedure. Okay.
That is the whole point.
Got it. All right. So great, Dr. Poonam. And I want to, Dr. Poonam's son had annual function today. She missed that, and we're sorry for that.
He just returned back.
But she presented, and I really have to thank her for that.
Thank you so much.
We contribute in our studying, missing our family life sometime. That's actually a great point. Thank you. And thank you, Dr. Ashish, Dr. Jeet ma'am, Dr. Sani, Ashu sir, Raj sir for their inputs. And so our next journal club is on 20th. So hope to see you all there. Thank you, everyone. Good night.